Good morning, everyone. I'm presenting on behalf of Medicine 3 and my case is out of options. This is a case of Mrs. K, a 20 plus 5 weeks primary gravida booked outside, who developed one episode of gum bleeding while brushing her teeth with no other bleeding manifestations. And she gives history of gum bleed and EC bruisability since childhood. There's no history of fever with rash, joint pain, photosensitivity, or any other connective tissue disorder features. No fever with chills, neurological findings, or bloody diarrhea. The patient was not exposed to any medication that might have caused a fall in platelets. No fever, weight loss, anorexia, night sweats, or bone pains. And there's no family history of bleeding or platelet disorders and no history to suggest a recent infection. Examination was mostly unremarkable. There was no active mucosal bleed or bruise or petechiae at the time of examination. There were no lymph nodes, no hepatosplenomegaly. The uterus was consistent with 22 weeks of gestation and fetal movements were present and fetal heart rate was heard. These were the basic investigations that were there. Uh, there's a there's a mild anemia, which was actually a normocytic anemia with a significant thrombocytopenia with a platelet count of 8,000. The coagulation parameters, renal functions, liver function, urine routine, and hemolytic markers were all negative. So the diagnosis that we considered in this primary gravida lady with just going into a few more investigations, workup further for the thrombocytopenia. The bone marrow was done, which showed a cellular marrow with adequate megakaryocytes. ANA was negative, and antiphospholipid antibodies and lupus anticoagulant were negative. The BBVS screen was negative. So the diagnosis we were considering in this lady with this severe thrombocytopenia less than 50,000, that is at a count of 8,000, was a primary ITP in pregnancy. What I would like to highlight in my clinical meeting presentation is the during the management, the conundrum that we faced and how we the options that we used. So during the course in hospital, she was transfused with 2 units of platelets in view of the bleeding at that point of time and given a pulse dose of dexamethasone. So this was when the pulse steroids were given. And then there was no, after the pulse was done, she was initiated on azathioprine and prednisolone at 70 mg, with which there was no resolution of the thrombocytopenia. It persistently remained low. At this point of time, she was on Azoran and prednisolone 60 mg, but the TPMT enzyme that was sent showed a borderline low activity. And in view of that, we had to stop azathioprine. The other options that we had and we considered were, one was because it was a primary ITP, we considered rituximab. But since she was pregnant and with the limited data available for rituximab, the use of this drug was not recommended, specifically because of its immunosuppressive action and the risk of infection in the fetus. The other drugs that could have been used, but because she was pregnant, we could not use, were MMF, cyclophosphamide, Vinca alkaloids, and danazol. A splenectomy could have been performed, but which would have yielded good results, but because of the pregnancy and because of the risk of bleeding and infection, it was deferred. If at all a splenectomy was to be done, it should have been done. It was the ideal time to perform it because she was in the second trimester. Because early splenectomy carries the risk of abortion, and later ones would be difficult technically because of the gravid uterus. This is at this point of time we considered a class of drugs called TPO receptor agonists, romiplastim, eltrombopag, and avatrombopag. These are drugs that have been used for ITP. These are drugs that stimulate the thrombopoietin receptors on the hematopoietic stem cells, and they have been used. But what was unique in our case was there's very limited data on its use in pregnancy, and most of the available data came from case reports. And specifically romiplastim, it lacks robust data about human fetal risk, but in animal models, it is shown to increase fetal mortality. There were certain risk factors with it, like thromboembolic complications, but that is primarily due to an increase in the platelet count and the subsequent thrombocytosis. And with adequate dose adjustment, that risk could be obviated. So based on the limited data that we have, it appeared that romiplostim was going to be safe. There was a multi-center retrospective study of 15 pregnant women in whom this therapy was given for ITP, and there were no maternal thromboembolic events. And thrombocytopenia cases were seen only in 6 out of 17 neonates. So there was an overall favorable response to that therapy. So we discussed these potential adverse events as well as the other unknown adverse events that could potentially happen with the patient. And ultimately, it was decided that the benefit of potentially treating her refractory ITP outweighed the potential risk for the fetus. So we started her on romiplostim injection, and subsequently we noticed that there was a very good response to the drug. And currently she's now gotten 5 cycles. This is a weekly injection. She's gotten 5 cycles of the same, and she's been following up with us in the OMC clinic, and the last platelet count was 1.98 lakhs. This is just to highlight that this was a drug that was we chose this medication mainly because of the lack of options that we had. We could not use this was a ITP that was refractory to steroids and IVIG, and azathioprine could not be used in her because of the fact that TPMT levels were low, and we ended up using this, and it showed significant response, and it was a learning point for us. So it's a good alternative for use in ITP that has failed first-line therapy in pregnant women.
Thank you. Very nice presentation. Any comments, everyone? Did you mention that even before pregnancy, she had gum bleed and skin bleed from childhood?
In childhood, she gives a history of the same, sir.
Then is it correct to say it's ITP of pregnancy? That's what diagnosis
not
was.
Of pregnancy. It's an ITP.
There's an underlying ITP which got picked up during pregnancy.
Yes.
I guess it's a bit easier to use a new drug like this when it's little later on in pregnancy. He has 20 weeks. Well, the whole story was in 8 weeks.
Yes.
Then it's not as easy a decision because any risk to the fetus will be more, implications are more in the earlier pregnancy.
Yes.
Okay, I think there are no comments. Thank you.